Alhamdulillah Rabbil Alameen wa salatu wassalamu ala rahmatil alameen. Assalamu alaikum. I trust all is good and sound at your end. Today we are going to talk about hyperaldosteronism. But before we further discuss about this topic, a quick brief overview about the aldosterone secretion and function. As discussed in the previous video, aldosterone is a mineralocorticoid which primarily regulates the sodium and water inside the body. It is usually secreted under the influence of renin, angiotensin, aldosterone system known as RAS, or when there are high levels of potassium inside the blood. It is secreted by the adrenal gland and it acts on the principal cells which are abundantly found in the distal part of the DCT, distal convoluted tubule, and the collecting duct. So this was a brief overview of the aldosterone function. Then in these cells, it primarily wants them to reabsorb more sodium and secrete more potassium. So now, what is hyperaldosteronism? Hyperaldosteronism means increased level of aldosterone inside the blood, which can be primarily due to a defect inside the adrenal gland or due to any secondary underlying disease. When we say primary in the endocrine system, it means the defect or the disease is inside the gland which is secreting the hormone. When we say primary hyperthyroidism, it means a defect or disease whether the thyroid gland is causing increased secretion of thyroid hormone. Similarly, when we say primary hyperaldosteronism, it means due to a defect inside the adrenal gland, there is more and more secretion of aldosterone. So now, when we can suspect a patient suffering from primary hyperaldosteronism, the next point number 3, which is saying resistant hypertension. So what is resistant hypertension? Resistant hypertension means a blood pressure of more than 140 by 90 millimeter of mercury, even after the use of 3 antihypertensive drugs, which include a thiazide diuretic. So in such a case, we suspect hyperaldosteronism and we do a screening test. So the other presentation that can be in this case is decreased levels of potassium, as we said the function. So if there is a decreased level of potassium, it will cause muscle weakness, and another, it causes the cells, the same principal cells, not to react to ADH, antidiuretic hormone. So a patient suffering usually from hyperaldosteronism will be suffering from resistant hypertension and maybe as well as muscle weakness, polyuria, and polyuria is secondary to this defect as just discussed. So the screening test here is aldosterone and renin levels inside the blood at 8 a.m. So you would assess or check both of these inside the blood at 8 a.m. and in the case of primary hyperaldosteronism, this would be increased while renin would be decreased, and the ratio would be more than 20. This ratio would be more than 20 usually. So in such a case, the next step would be to confirm, just as we studied in the Cushing syndrome in the previous video. So the confirmation test here can be oral salt loading test, or it can be saline infusion test. So oral salt loading test would take usually 3 days to intake a high quantity of salt, and then we would check aldosterone, maybe in the urine. In saline infusion test, you just give 2 liters of normal saline, and usually after a few hours, around 4 hours, we check the levels of aldosterone inside the blood. So if these tests are positive, so primary hyperaldosteronism is confirmed, and then we do a CT or MRI of adrenal glands, CT MRI, because now we know the primary defect is inside the adrenal glands. Now, in this case, there can be usually bilateral adrenal hyperplasia, okay, which is most of the cases, or there can be a adenoma, or there can be a carcinoma. In case of the carcinoma, the lesion is usually more than 4 cm, and you would do surgery. The definite treatment here is surgery. In the case of adenoma, we usually have to confirm. How do we know if it's adenoma? Usually the size is less than 4 cm, and it appears to be unilateral, and maybe it's an adenoma. So what will we do? We do adrenal vein sampling. And if in this sampling, unilaterally there is more aldosterone, so it's confirmed that it's an adenoma. Now it depends the treatment. It can be surgery plus minus Medical treatment. Now the medical treatment include say aldosterone receptor blocker or a spironolactone drug. So it depends, of course, on the case scenario or the endocrinologist, but you should know undergraduate level should know until this adenoma, carcinoma, and bilateral adrenal hyperplasia is usually medically treated, not surgically treated. So bilateral adrenal hyperplasia. So of course, if it's not carcinoma, adenoma, so it's bilateral adrenal hyperplasia. So this is the primary. We are talking about the pathophysiology and medicine of primary hyperaldosteronism. In the case of secondary hyperaldosteronism, so in that case there would be more aldosterone as well as more renin, and we will discuss this in the next video, that is the part 2 of hyperaldosteronism. Thank you for watching, and you can subscribe if you find the videos useful.